Hello everybody, I hope you're all taking care of each other. My name's James Piper, I'm a Senior Clinical Teaching Fellow at the Royal Free Hospital in Acute Medicine. This is a specially adapted talk for preparation for Practice Week and the Year 4 Acute Medicine students here at UCL. What's important to appreciate at this time is that this is an algorithm that's designed for non-COVID-19 patients. There is an algorithm for COVID-19 patients available on the Resus Council website, and it's important to realise that this is for non-COVID patients. The aim of this lecture is to understand the ALS algorithm, to understand the importance of high quality chest compressions, state the treatment of shockable and non-shockable rhythms, know when to give drugs during cardiac arrest, treat potentially reversible causes of cardiac arrest, and to understand the roles of within the resuscitation team. I would add that the last point is probably the most important. There are four key aspects of the chain of survival: early recognition and call for help, and early chest compressions, early defibrillation, and post-resuscitation care. Obviously, where possible, we want to avoid our patients having a cardiac arrest. As you'll imagine, the mortality is very high, or we want to prevent them from having an unnecessary cardiac arrest. So it's important that we recognise our patients are deteriorating, and I'll come on to this in a moment, and calling for necessary help. Good quality chest compressions are absolutely vital in order for our patient to potentially survive a cardiac arrest, as well as putting on the defibrillator. For the vast majority of patients who have a cardiac arrest in hospital, it is likely to be non-shockable. Therefore, for those, albeit in the minority, that we are able to shock, it's important that we do so quickly. If we don't do this, the outcome will fall significantly. So in my previous days as an ITU registrar, obviously there are lots of things that we can do in ICU, such as mechanical ventilation, cardiovascular support. However, when we think about what outcome do we want for our patients, ideally we want them to survive neurologically, have a good outcome, and be able to leave the hospital. None of that matters what I do in ICU if the first three things are done poorly. To give you some idea about the data, so generally speaking, contrary to what you might think, the typical survival rate for a non-shockable rhythm in hospital is only about 8 to 12%. This is often contrary to what people think, as people might say, well, you've got all of this equipment, you have resuscitation team, you have expertise, surgery, interventional radiology. That's true, but it's important to remember about why these patients have come into hospital in the first place. Is it that they have deteriorated from the thing that brought them in the first place, such as, let's say, pneumonia? Or is it that they've then deteriorated and arrested due to a complication of the thing that brought them in the first place? So, for example, a patient who comes in, who's already frail, has a severe community-acquired pneumonia, has been in bed a number of days and developed PE, and then has a cardiac arrest due to massive pulmonary embolism on top of the hypoxic insult from the pneumonia. And that's why, unfortunately, our patients don't survive in hospital. This slide here is a copy of the ALS algorithm, and we're going to break it down into its constituent bits. You can see it looks rather busy, but actually when you break it down into its simplest parts, it's actually fairly straightforward. I want to talk first of all though about the early recognition of a deteriorating patient. For those of us who work in acute and critical care medicine, this is absolutely a vital skill, and it's important that for yourselves as year 4 students, that as you progress towards your year 6, you're able to ask this simple question: what does a poorly patient look like? And for those of you that have done acute medicine with me, you'll know that we've been through some of these things before, and hopefully already you'll have a good idea. For those of you that haven't, I'll be organising a separate tutorial for those that aren't at Royal Free Hospital called Principles in Acute Medicine, where I'll be able to give you the answers. What is true to say, first of all, is that most arrests are predictable. Now, often when I ask this question in a classroom, I get a range of answers between 30 minutes and a few hours, but the actual answer is that you can predict a cardiac arrest for between 8 and 24 hours before it happens. And actually, if you look at the chart on your right, it gives you a good example of why that is. Now, you might not be able to see the numbers very closely, but that's okay. On the first column, you have the 17th of the month, and on the right-hand side, you see the 20th. There's a 72-hour period here. Now, let's scrutinise this chart a little bit. It's been signed lovely. It's neat and tidy. Someone's even put sleeping in the AVPU section when actually the patient's deeply unconscious. And you'll notice if you look above, they have what's otherwise known as the seagull sign. And that's basically where you have the seagulls plopping onto the patient. And this represents where the heart rate is much higher than the blood pressure, and obviously that's abnormal. Now, it says that deterioration is up to about 80% of cardiac arrest. Now, that's true, but it's important to appreciate the patients that you have in front of you. So what do I mean by that? Well, for example, a younger person, for example, is much likely to tolerate better an insult such as hypovolemia or sepsis than a frail one. For those of you that have also done acute medicine with me, you'll be familiar with the trajectories of disease, and so you'll know that younger people can hold out, i.e. they have normal functioning hearts, they can vasoconstrict, they can make their heart work harder, so therefore they can cope until a certain tipping point, and then they deteriorate very rapidly. Older people, however, or those who have comorbidity or frailty, for example, may have, say, peripheral vascular disease, reduce their ventricular systolic function, peripheral vascular disease, and so their vascular compliance, their ability to make their heart work harder, for their valves to be more efficient, and for blood plasma to be transported around becomes much less efficient, therefore a much bigger challenge to get over an acute and critical illness insult, and therefore they will deteriorate at a much steeper trajectory. Now, it says that hypoxemia and hypotension are common, and that kind of sounds true, but by definition, as you can't have a cardiac arrest if you still have a pulse and blood pressure. But again, this comes back to the point that I was saying before about hypoxemia, for example. Younger people will be able to ventilate a lot harder, and so often they will tip over at the point of exhaustion. Older people who will have, for example, COPD will not cope as well, and they will tip over much quicker. It's important to identify this window period of when we can decide about what we're going to do with our patient. Is it that we're going to palliate them? Is it that we're going to make them for ward-based care? Is it that we need to escalate them to my colleagues in critical care? And using this time window wisely is critical, as if we get a patient to ITU who's already had a significant hypoxic insult and had hypoxic brain injury, you may know that hypoxic brain injury is not reversible, and therefore it doesn't matter what I then do for the patient in ITU if they already have ischemic insult. Therefore, using this window wisely is crucial. Hopefully you'll all by now be familiar with the National Early Warning Score. We're on to our second version now, and I'll highlight the key differences now. The main one being is that you have a scale 1 and a scale 2 for saturations of oxygen. What's really important to appreciate is that all of your patients should be on scale 1 unless two things: they are known to have type 2 respiratory failure or severe COPD, and most importantly, a senior doctor has agreed that they should be on scale 2. Unfortunately, there have been significant incidences where people have been put on scale 2 inappropriately and have obviously had significant harm done to them as we've not been treating them properly. Remember, it is hypoxia that kills these patients, not hypercapnia. The respiratory rate is fairly straightforward. Unfortunately, this is the observation that's often done the most poorly. What we should be doing, for those of you that remember from your year 1 OCAPs, about counting a respiratory rate over 1 minute. It is the most sensitive marker for acute illness, but it's often the one that's done badly, i.e. people cheat, count for a few seconds, multiply by 2, or actually just simply look at the patient and guess. You can see when the oxygen scales that actually it doesn't take long for you to get to a 3 points. So actually it only takes 5 percentage points in your saturation scale for you to start triggering a 3. I take issue slightly where it says air versus oxygen, because as you can appreciate, if you're just on 2 litres of oxygen, that's very different to a patient requiring a 15-litre non-rebreather mask. Systolic blood pressure, well, you can look at that and go, well, hang on a minute, how can it be that you can have a blood pressure of 210 but score a 0? Well, the simple answer is that all patients are different. Hypertension in itself is a very common medical problem, but rarely a true emergency. And some patients, for example, depend on a high blood pressure, for example, chronic kidney disease. And actually, if you drop the patient's blood pressure very suddenly, you'll give their kidneys ischemic insult. Similarly, in stroke, the brain gets regulated to that high cerebral pressure, take that pressure away, and you might extend someone's infarct. Hypertensive encephalopathy, or literally a blinding headache, is relatively rare. Pulse is fairly straightforward. We've also added in confusion into the scale, and again, you're going to be mindful of the different presentations or differential diagnosis of confusion in younger and older people. The distinction is important. Most of us are all, I'm sure yourselves included, are very familiar with the concept of fever. Most of us know what to do, for example, sputum, blood cultures, full blood count, CRP, taking blood cultures, and so on, and thinking about antibiotics, but we don't often think about hypothermia. It's important to realise that as the brain ages, the hypothalamus doesn't work very well, and it might well be that actually your patients who are frail, have little in the way of skin, fat and muscle mass, may often will become hypothermic much quicker than someone like me who's got a little bit of excess fat than we'd rather like. So to confirm cardiac arrest, you want to check the patient's responsiveness. So we use what's known as a trapezius squeeze to squeeze round the shoulder. You previously may have seen where we do sternal rub, apply supraorbital pressure. That's been deemed abuse, and actually if you think about rubbing your own chest, how hard you have to rub in order to make a difference when rubbing someone's sternum. You want to do a simultaneous head tilt chin lift and feel for a carotid pulse. You want to be looking at the patient, as you can see in the picture, for any signs of life. You want to be doing this for up to 10 seconds. I just want to stress again, it is really important that you don't spend too long feeling for a pulse. I'm going to blind you with science now when I say patients who are in cardiac arrest look like they're in cardiac arrest, and actually spending time trying to feel for a carotid pulse that isn't there is simply going to delay the onset of chest compressions, and therefore your patient is going to do less well. You do want to be on the lookout for what's known as paradoxical breathing or abdominal breathing. This is when you see the chest barely rise, but the stomach do all the work. Now the reason for this is, as you can imagine, if you start to breathe harder yourself, eventually you're going to get tired from doing that. Eventually you'll get respiratory muscle fatigue, and because your lungs are ultimately also controlled by the diaphragm, which is controlled by the brain, it is the diaphragm that is still trying to make the patient breathe. But however, this is a terminal sign and your patient is going into cardiac arrest. As soon as you have identified that the patient is in cardiac arrest, it's important that you call the resuscitation team, and we do that using 222 from any NHS phone. You want to then immediately start chest compressions in a ratio of 30:2. Now the 2 bit assumes that you have a team available and you're giving the patient oxygen. If you are on your own or with a single person, then you must just do chest compressions only. Indeed, if you are on your own, then you should immediately go and get some help and raise a 222 and then come back and resuscitate the patient. If there are 2 of you, one of you should go for help and the other should do continuous chest compressions. If there is a team of you, then that's different, and that's when you can apply multiple things at once, such as the defib pads, bag valve mask, chest compressions, and go and raise the alarm for 222. Your chest compression should be in a ratio of 30:2, as I was just saying. However, if there's no airway device, then just do continuous chest compressions. Certainly in the time of COVID and other respiratory infections, it's important that we do not ever use either a pocket mask or mouth-to-mouth resuscitation. If you know the person, then obviously that's your free choice, but certainly in the general public or a hospital inpatient, we would never advocate that. Chest compressions, the power comes from your shoulders. You should have straight arms, centre of the chest, 5 to 6 centimetre depth, and about 2 per second. For example, I have on my phone a metronome that I use to time my compressions. There should be minimal interruptions to chest compressions. So, for example, this is why I was saying at the very beginning that your teamwork and your communication skills are really vital in a situation like this. If you have a airway doctor who's able to put in a supraglottic airway or an ET tube, then the patient can have continuous chest compressions. I don't know if any of you have done chest compressions on a real patient before. I have many a times in my career, and it's extremely tiring. And certainly at the moment with COVID-19, wearing the full PPE, trying to resuscitate someone is absolutely exhausting. So think about each other, think about yourselves. Could you do chest compressions for a whole 2 minutes? Some of you will probably be able to, others not so. And if you can't, that doesn't matter. We'd much rather you swap at regular intervals, such as 1 minute, and give high quality chest compressions rather than try and flog yourself for 2 minutes instead. So what you're wanting to do is, whilst you're doing chest compressions, and again without interruptions, you want to put the pads on. You want to communicate that you're just putting the pads on, and that the person doing chest compressions should be allowed to continue until the pads are on, they are in an appropriate position, and that you've turned the monitor on, ready to do a rhythm check. Once you've done the rhythm check, you want to have a look and see whether it is a shockable or a non-shockable rhythm. As I was saying at the beginning, unfortunately most of our patients will have a non-shockable rhythm. If you are lucky, and I use the term lucky loosely, to have a shockable rhythm, then the most important thing, of course, is to defibrillate them immediately. Shockable rhythms include ventricular fibrillation, which is what you can see here, and to put it simply, the heart is basically quivering and needs that electrical shock in order to stop and then restart again. It has a bizarre irregular waveform, and there are no recognisable QRS complexes. Some of the defibrillators, if you're not careful, will show chest compressions as either VF or VT. So it's really important that when you're doing your rhythm check, whoever is doing chest compressions, they are asked to pause momentarily and make sure that you don't mix up VF with artifact from chest compressions. This here is VT, or otherwise known as very tidy, and you'll notice that you have VT in pulseless VT rather in brackets. Well, so why is that? Well, if you think about ventricular tachycardia, you can either have VT with a pulse or pulseless VT. Well, what's the difference? Well, there's two things that will make a difference. Number one is the rate of the VT. The second thing is the physiological fitness of your patient. Now, most of us, I think, would cope quite well with a VT at a rate of 120. But if I think about Doris, who's 95, who has poor left ventricular function, bit of aortic stenosis, bit of mitral regurgitation, then actually a VT of 160, she is not going to cope with that, and she'll very quickly become pulseless VT. So it's those two things that will often make the difference between VT with a pulse and pulseless VT. If you identify a shockable rhythm, you want to immediately restart chest compressions. You want to charge the defibrillator. So on some defibrillators, it'll be a starting value of 200. Others, it'll be a one starting at 150. It's important that you are aware of the defibrillators that you're working in across the sites. As the defibrillator charges, I have 3 golden commandments for safe defibrillation. The first one is to make sure that someone is continuing to do chest compressions. The second commandment is for oxygen to be away. Third commandment is for everyone else stand clear, so that when you defibrillate, you're only really looking at the bed where everyone should be clear apart from the person doing chest compressions, and you're then telling the person doing chest compressions to stand clear out the way. You then discharge the energy and immediately restart chest compressions. There should be minimal interruptions throughout your chest compressions. Now, in terms of delivering drugs, to keep it very simple, there are two times in which you give drugs. In a shockable rhythm, such as VF or pulseless VT, it's after the third shock in which you would then give 1 milligram of 1 in 10,000 IV adrenaline and 300 milligrams of IV amiodarone. If, however, it's non-shockable, you would give the adrenaline straight away and no amiodarone. In the vast majority of cases, unfortunately, in hospital, there's going to be non-shockable, and there are a few examples here. This one is a systole where you can see it's not quite a flat line, but it's essentially so, hence the term. If you see a broken line, dot dash, dot dash, dot dash, actually that is a connection problem, and you need to make sure that the pads are still on. But a continuous waveform with no meaningful activity will be a systole. What's really important in PEA is that you can have any rhythm that's organised electrical activity. So, for example, at the top one you have an SVT, the second one you've got a complete heart block. It doesn't matter what those rhythms are. If there's no pulse, then it's PEA, your diagnosis in cardiac arrest. It's important that you don't get fooled by that or caught out or attempt other things when the patient just needs CPR and adrenaline. During chest compressions, you want high quality chest compressions, minimal interruptions, oxygen, which I'll come on to in a moment. Use a waveform capnography, or otherwise known as end-tidal CO2, to monitor your waveform and also to make sure that if the patient has an ET tube in, that you can see the ventilations and you know that it's in the patient's chest rather than their esophagus. Once you have an advanced airway doctor, such as an anaesthetist or airway specialist, come in who can give continuous chest compressions when an advanced airway is put into place. IV access is important, and you'll find that when you're in your FY1 years, very often you will be asked to put in a cannula in a cardiac arrest. Give the adrenaline every 3 to 5 minutes after it's initially been given. So just to clarify, in shockable rhythms you give your adrenaline and amiodarone after the third shock. If your patient, however, is in cardiac arrest, you then give the adrenaline every other cycle. In non-shockable rhythms such as PEA, you give your adrenaline straight away and then every other cycle after that. You only give amiodarone after 3 shocks in a shockable rhythm. If, however, after a second round after that, you may give a further dose of amiodarone if required. Vascular access, so most of you will have all been used to by now putting in cannulas, and there are a number of ways, however, we can achieve vascular access. The most common one, of course, being peripheral cannulation. I don't know if any of you have tried it, but cannulating someone who has no blood pressure is pretty tricky. We can sometimes use emergency central line access. So, for example, there have been occasions where I've put in a blind femoral line. However, this is extremely tricky. You have to be a bit of a dab hand of it, and obviously this isn't something that we're training you to do at this stage. Another thing that we are is encouraging you to think about intraosseous access, where you use a drill and a hammer and you can drill into the bone marrow. If you go on YouTube and Google EasyIO, you'll be able to see how that process is done. I was talking a little while ago about waveform capnography, and you can see in the picture that the patient has a tied ET tube in situ with a thin tube that comes just before the catheter mount that appears to go away from the patient, and that's known as the end-tidal CO2, and that effectively measures the exhalation of carbon dioxide. And because carbon dioxide is a nice steady gas, it makes it nice and easy to measure. So, for example, if you have an ET tube in the lungs, as you ventilate your patient, of course, you'll be ventilating oxygen in, and CO2 you'll be letting exhale. And the exhalation is what you will see on the monitor. And you should see a nice M shape as the patient breathes in and out. We use it to confirm the correct tracheal tube placement, monitor the ventilation rate, quality of chest compressions. If, for example, your patient starts to ventilate and they start to cough against the tube, you'll start to see a sort of a jagged line or a wavy M line as the patient starts to breathe. This slide here demonstrates what are known as commonly known as the 4 H's and the 4 T's. Now, these are often lists that people quote or run through in a cardiac arrest situation, and if you've been to a cardiac arrest, you may hear these being discussed. I'm going to go through all of them now, but it's important to realise that these are singularly reversible things. Now, unfortunately, our patients don't often have singularly reversible things, and I'll come on to that in a moment. For those of you that have worked with me, you'll know how passionate I am about frailty and recognising frailty states and thinking about non-reversible causes. So if we go back to the list for a moment, you will see, for example, hypoxia. What if that hypoxia, for example, is caused by lung cancer and the patient has massive pleural effusion? Now that's not going to be treatable nor reversible in a cardiac arrest, and that patient should have a DNAR or a very quick decision to abandon the resuscitation. One scale that I suggest that you become familiar with if you're not already is the clinical frailty scale. This is the frailty scale that is currently being used in the COVID-19 epidemic. And if you, for example, search on NICE guidance with decision making in COVID-19, you will see the clinical frailty scale used as a basis for decision making. And it's a very simple scale that goes from 1, very fit, to 9, where they are terminally ill. It's always important to think about frailty as a non-reversible cause. If we're concerned about a patient having hypoxia, then you want to administer high flow oxygen via a patent airway. Now, it's important to distinguish between giving oxygen as a treatment. There aren't any situations where I can imagine where we would deprive a patient of oxygen during cardiac arrest. That would obviously lead to a catastrophic outcome, and the actual distinguishing hypoxia as a cause of cardiac arrest. So, for example, what do I mean by that? Well, obviously we're going to give all of our patients oxygen, so have a think about what has the trend in their saturations been. Have their saturations been dropping slowly all day? Could it be that actually the patient has developed a massive hospital-acquired pneumonia, massive pulmonary embolism? Do they have a massive effusion from perineumotic effusion or malignancy or something like that? That's really what you should be asking. Look at, for example, the patient's imaging and obtain a blood gas. When we administer or use airways in a cardiac arrest, I've put up a picture of 4 ones that should be used as a bare minimum in cardiac arrest. On the top left, you have a nasopharyngeal airway, which will vary in size. Typically, you'd use a size 7 for patients that are relatively on the larger side, and so on. Oral pharyngeal airways, supraglottic airways, these are otherwise known as I-gels, and an endotracheal tube. In order to use an endotracheal tube, you must be able to use a laryngoscope. An ET tube should only ever be inserted by people who have advanced airway training, such as an anaesthetics trainee, an acute medicine / ICM trainee, an ICU registrar, or a consultant anaesthetist or registrar in anaesthetics. Hypovolemia is the next one. You want to seek evidence. So again, what has their blood pressure trends been? What is the history of the patient? Is it, for example, that they've been brought in following an RTA and you're concerned about splenic injury or aortic injury? Have they got, for example, a history of a large aortic aneurysm? Have they recently had surgery, for example? Have they recently had a biopsy, so for example, a renal biopsy? What's been the blood pressure trends? What is the patient's HB level? Is there any evidence of DIC? Examine the patient. Is there bruising somewhere? Are you worried about internal bleeding, say from a pelvic fracture? Is there external hemorrhage, say from a gunshot or knife wound? Does the patient have surgical drains? Is there a massive hemothorax? Is it that there has been a patient that's had, for example, a laparotomy and they've had an intra-abdominal bleed? You want to control the hemorrhage, and you want to think about how you're going to do that. Is it, for example, if I cut your finger, you put direct pressure on it? If you've got an arterial bleed, you want to put, say, external pressure on and summon a vascular surgeon. If you have an internal bleed, is it that you need to go to theatre and have an emergency laparotomy? Is it, for example, you've got a pelvic fracture, you want to put a pelvic binder on and secure the pelvic ring? If hypovolemia is suspected, you want to give obviously intravenous fluids and blood products. you also might consider activating the major hemorrhage pathway. One of the earlier tests that are done in a cardiac arrest is a blood gas, and this is usually venous, but if you can get an arterial sample, then all the better. You want to put it in a blood gas machine and check obviously your PO2, pH, CO2, lactate and so on, but also in hypo and hyperkalaemia and metabolic disorders you want to check the potassium and the glucose. You want to check the latest laboratory results. If the patient has hyperkalaemia, then you'd give them 10 ml of calcium chloride in cardiac arrest, gluconate in peri-arrest situations, and insulin and dextrose. For example, 10 units of fast-acting insulin in 50 ml of 50% dextrose. In the ALS manual, it's often referred to as 25 grams of dextrose. For hypo situations such as hypokalemia and hypomagnesemia, then obviously in hypokalemia you would need to organise strong potassium infusion such as 40 millimoles in 100 ml of saline stat. Funny enough, people always perhaps make me chuckle a little bit when assessing people in their cardiac arrest stations doing ALS courses. They often quote with me hypothermia. Well, unless your patient's an Arctic explorer or has, for example, been of no fixed abode and has been out all night, perhaps either of no fixed abode or partying all night, then actually hypothermia as a cause of cardiac arrest, certainly in the UK with all of this lovely weather that we have, actually is extremely rare. And we haven't yet started suspended animation, so our patients aren't kept in an icebox. So hypothermia is a relatively rare cause of cardiac arrest outside of the emergency department environment. If that is the case and you're doing an ED shift and the patient has hypothermia, then you can use things like rectal thermometers, esophageal thermometers, and we would consider active rewarming techniques such as by cardiopulmonary bypass, warm fluids, and a bear hugger, as what you can see in the picture. Tension pneumothorax, we may see these in those who have chronic bullous lung disease, those who have, for example, cannabis smokers and have popped a bulla and then develop spontaneous and then tension pneumothorax. Often more commonly it's seen in chest and thoracic trauma such as stab wounds or GSW, or otherwise known as gunshot wounds. You want to see if there are decreased breath sounds, hyperresonant percussion notes, and as you can see in the diagram, what's happening is that the lungs are acting as a one-way valve, and as the patient breathes in and out, they pull atmospheric air into the lungs, and therefore, but they can't escape, so the lung just expands and pushes across all of the major vessels and the heart, which will ultimately then cause hypotension and the urgent need for needle decompression. Cardiac tamponade is again something that's often quoted but rarely seen. It is very difficult to diagnose cardiac tamponade without an echo, and I've put a line there to see where you can see the black fluid that is surrounding the left and right ventricles, which is causing the cardiac tamponade. Most likely it is going to be seen after penetrating chest trauma or after cardiac surgery. You would need a specialist registrar in cardiology to come and do a needle pericardiocentesis, or in worst case scenario, cardiothoracic surgeon to reopen the chest and do a pericardial window via resuscitative thoracotomy. For those of us that work in acute and general medicine, thrombosis is often high on our differential diagnosis list. If it is considered that the patient has died of massive PE, then we may consider thrombolytic therapy, such as alteplase. Each trust will have a different protocol for giving therapeutic agents, but certainly you'd want to consider the appropriateness of giving fibrolytic agents. If that decision is made and the patient is for ongoing resuscitation, it's important to realise that thrombolytic therapy can take 60 to 90 minutes to work effectively, i.e. the time it takes up to break the clot and potentially restore organ perfusion, which, as you can imagine, to do that for an hour and a half is a significant insult to the patient and requires a huge amount of manpower. Some places will be lucky and they'll have what's otherwise known as a Lucas machine, or a chest compression device, which is slid on top of the patient and effectively acts as a jackhammer, administering chest compressions as a machine. and toxins. So you want to be looking for two different types here. So is it that the patient has deliberately taken something? Is it an alcohol overdose, recreational drug, so for example GHB, a common recreational party drug? Is it something that we have given them, either prescribed or we've overdosed someone by accident? So for example, patient who goes for an endoscopic procedure has too much fentanyl, too much midazolam, and therefore their respiratory rate falls, and then they may go into cardiorespiratory arrest. If you're unsure, you can use ToxBase, the British National Formulary, or the National Poison Service for reference guides. So airway and ventilation, just as a recap, you want to, where possible, secure the airway. That said, there are some studies which actually show that a bag valve mask versus an ET tube in cardiac arrest cause similar outcomes. So I would always just say to anybody, do what you can, do what's right, do what's safe. And remember, the right airway for the patient is the right airway for them, not the one that you think it should be. It's always important to bear that lesson in mind. Never attempt intubation unless you are trained and competent. Once the airway is secured, you can do continuous chest compressions. Consider things like ultrasound imaging, and although ultrasound is very trendy these days, you have to be a very experienced ultrasonographer to get diagnostically useful, high quality images in a very rapid space of time. For example, in my career lifetime, I've only had one sonographer who has been able to give me useful images in time when the patient had a massive PE some time ago. If you're lucky to get return of spontaneous circulation, you want to think about post-cardiac arrest treatment. So you want to, again, resuscitate your patient using an A-to-E approach. You want to try and normalise their carbon dioxide and their oxygen levels, do a 12-lead ECG. Is it that they've had an ischemic insult and they need a primary PCI plus or minus stenting? Is it that they need an urgent CTPA to look for pulmonary embolism? Is it they need a CT head to see if there's any evidence of hypoxic brain injury? And you want to try and treat the precipitating cause. But again, it's important to remember that resuscitation is not over now. In fact, if anything else, you're starting a new phase of resuscitation. If you imagine just for a moment that I've been jumping up and down on your chest and broken a whole lot of ribs, then again, you're probably going to have issues with pain, broken ribs, possible pneumothoraces. You may have aspirated. There are lots of now new pathologies that you're going to have to address now that your patient has got return of spontaneous circulation. So resuscitation is far from over. And it may be that even if you are successful, and I use that term loosely, you may find that the patient has had such a catastrophic insult from their cardiac arrest that it might be actually more in the patient's best interest to give them palliative care instead. Resuscitation and acute medicine is an absolute team sport. Most of us will know each other from working on the wards closely, and so we'll know our own skill sets. And so we'll know what particular assets we have, such as airway skills. In my role as a medical registrar, obviously I'm often the team leader by default. I let my colleagues from anaesthesia take over the airway, and I let my colleagues, for example my FI1 SHOs, will often do the cannula and do, for example, the rhythm check and administer the shock. Resuscitation can either be very straightforward or very chaotic, and very often most people know how to use a defibrillator and do chest compressions and blow some air into someone. What isn't often done so well is the communication, your ability to task manage, teamwork, situational awareness, and your ability to make decisions. This is a really important skill to develop at your stage in year 4, so that you have that capacity and situational awareness when you get into year 6 and become fully fledged doctors. You want to think about structured communication, such as an S-bar handover, particularly if you're referring a patient to a speciality such as intensive care medicine. And as part of your PfP week, you'll also do a handover station where I want to think about S-bar, the situation, what's the headline. So for example, this is Mr. Smith, who has just had a cardiac arrest. What was the background? Well, he has known ischemic heart disease, has been on CCU for 2 days after an NSTEMI, suddenly went into pulseless VT, defibrillated ×2, had successful return of spontaneous circulation, no drugs administered. ECG shows 12 lead ECG shows marked new ST elevation. We did a quick echo, ruled out cardiac tamponade. He needs to go for urgent primary PCI and into cardiac ITU. Would be an example of an S-bar handover. Thank you for listening. If you have any questions, please email them to me at james.piper@ucl.ac.uk. I wish you all the very best at this very difficult time. If you have any questions or any requests for topics from me, especially those of you that are doing or have done acute medicine, please do email me, and I'm working my hardest to get these voiceover lectures ready for you. I'm missing you, and good luck. Take care, everybody.